Good day and welcome to our webinar. First, do no harm, how clinicians can champion the end of medical debt. I hope everyone can hear me and see me okay, and there should be a screen with a welcome sign of the name of the presentation for you all. For today's webinar, I will be hosting and kind of facilitating the flow through the webinar. I'm Gregory Brody, so I'm the program manager for community engagement at Undo Medical Debt. And I will be opening the call today. So just a quick overview. Um, Here we are opening, welcome. We'll be doing a research overview to kind of contextualize the work that we've done and the product of the toolkit that we'll be presenting on. As well, we'll be doing a one-on-one constituent interview and a physician interview as well. Following that, we'll be doing a conversation around community collaboration, and that's when, towards the end, we'll have some time for question and answer. We'll close out the call and think through some next steps as well. Just some housekeeping as we're starting the call. This call is being recorded. That is so that we are also able to send this out following the call. So you'll have the video as a resource in addition to the slides. So slides and recording, and actually all of the resources, we'll be talking about a lot of resources today. We'll be mentioning them. These will all be included in follow-up. And lastly, please submit any questions that you have throughout into the Q&A section of the webinar. We will not be answering questions throughout. We'll be managing them towards the end for discussion. Any technical questions, obviously flag, and we have support on to help you sort that out as quick as possible. With that being said, I'm actually going to pass and we're going to dive into the research overview. And I will pass it to my colleague, Lindsay Zisdale, policy analyst at Undo Medical Debt.
Thanks, Gregory. All right, so I'm going to walk you through the research piece. So first, why this work and why now? So we know the medical debt crisis has only continued to grow and it threatens to undermine the already fragile patient-clinician relationship. Doctors and other healthcare workers are exhausted and they feel like the affordability crisis significantly hampers their ability to do their jobs. Basically, people want to do medicine. And we wanted to explore what clinicians and patients are feeling and thinking. So what can healthcare professionals do to help patients navigate a broken healthcare financing system while also making sure they receive the care that they need? And what kind of support do patients want from their doctors and other clinicians? So next slide. So to accomplish this, we launched this one-year project centered on focus groups, surveys, and deep dive interviews with clinicians and patients. We held 4 focus groups with a total of 30 clinicians from across the country. We heard from 89 patients with medical debt via survey, and then we held 4 deep dive interviews with self-identified clinician champions to end medical debt, along with 4 really incredible in-person, on-camera interviews with Undo constituents. Go to the next slide. So our guiding question in all of these efforts, what makes a clinician champion? And how can a clinician champion advocate for and embody the practice, policy, and systems changes that must happen to end medical debt? Next slide. And here's a little bit of what we found. So while the findings initially seem dire, and there's no doubt people are afraid and in need of support, there's also plenty of light to be seen. So we found that physicians and healthcare workers are struggling. Patients say they want more support on financial issues. We know that physical and mental health are inextricably linked with financial stress. Physicians and healthcare workers can champion the issue. And finally, champions take many forms. So we've developed a roadmap to help you start on your journey. So I would say overall, clinicians want to support their patients and be agents for change, while patients are far less afraid of having these conversations than we anticipated. Going into this, we were all kind of assumed that patients were apprehensive about having conversations over finances with their doctors. But instead, it seems like most patients expect these conversations and they want more from their clinicians. So next slide. And I'm going to go a little bit deeper into what we heard from healthcare workers in our focus groups and some of our deep dive interviews. And we had 5 top themes that emerged from our focus groups and these interviews. They provide important insight into how clinicians are thinking and feeling about medical debt. and where work can be targeted. So I'm going to walk through these and then I'll pass it on to Camila, who will explore the patient side more in depth. The next slide. So our number one theme, medical debt is a barrier to and within care. Both patients and healthcare clinicians change treatment decisions to avoid medical debt. Next slide. We have a couple of really clarifying quotes that go with each of these themes. So I'm going to let you sit with these as we go through the themes rather than read them out loud to you. We go to the next slide. So the second theme, cost of care conversations are relatively common, and patients are far less afraid to talk about medical debt with their doctors than we anticipated. However, clinicians feel they have very limited training and few resources to offer. We know that both parties want more formalized support and training. Doctors and clinicians want to be supportive and help their patients figure out these problems, but they also want some training in medical school or wherever else to help them know what they can point their patients to. So people feel a little bit adrift and want some more support. If we can go to the next slide. Next slide. This was another really big one. Everyone agreed that health insurance is important, but it's not enough. And sometimes it does make medical debt worse. And I am going to read a little bit from this next quote because I think it's very instructive. So we have a physician in North Carolina who shared with us, you can have insurance, but if you don't understand the type of insurance that you have, it can be pretty useless. They shared that they have patients who have gotten insurance off of the marketplace that have enormous deductibles. I think a lot of us have experienced this, and they didn't realize it. And so they go and get care, and then they're stuck with these huge bills that they didn't anticipate because they thought, well, I have insurance coverage. This is supposed to do that for me. And this is something that is pretty consistently coming up, I think, in the exam room. People are really not sure what insurance is supposed to do for them. Next slide. So the business of medicine has pulled clinicians away from practicing medicine, forcing them to become financial advisors on top of their other duties. And a lot of people note that this is outside of their purview. This is not what I'm supposed to be doing. But they also understand that they have no choice but to play this role. We heard a lot of, if I don't do it, who will? There's frustration with this, but also ultimately, most people view these conversations as beneficial. Sort of going back to the previous theme, they just want something a little bit more substantive to help them support their patients. And this also came up a lot if you go to the next slide. Patients trust their doctors. They do, and their other clinicians, and they will bring bills to their doctors because they don't, like they say here, they can't get through anywhere else. So in many ways, doctors are the first line of defense, but also, the last resort because there's nobody, people feel like there's nobody there in the middle. Next slide. And then finally, clinicians feel overburdened and limited in their ability to help tackle medical debt. Changing the system will require a collective effort from the government, health insurance companies, health systems, healthcare clinicians. It's not something that can be done alone. It's something where everyone in the system has to come and work together to try to figure out how to fix it. And this is an extensive quote on the next slide, but it's very powerful. All right, and then next slide, I'm going to hand it over to Camila Salvano, our Constituent Engagement Manager, to go deeper into the patient perspectives.
Thank you, Lindsay. So as Lindsay mentioned, for the purpose of this project, we talked to patients in two ways. We surveyed them regarding their experiences discussing medical debt and healthcare expenses with their physician or clinician, or even nurse or other hospital staff. Then we conducted long-form interviews with a smaller group of patients who felt motivated to share more about their relationships to their clinicians within the context of medical debt. Next slide, please. One of the patients that participated in our deep dive interviews will be joining us shortly. So Tammy, whenever you feel comfortable, please turn your camera on. Before Tammy and I get to talking, I invite everyone to look over the top themes, highlighting what patients see in their clinician champions. So, as Lindsay mentioned, there's an understanding that changing the healthcare system will require a collective effort. Yet, here are examples of small ways clinicians and doctors can show up for their patients and encourage them to receive care, even when struggling with affordability or medical debt. So, I'll give everyone a chance to go through this list. The biggest takeaway for us when we look at this list is that changing attitudes and behaviors and showing up as an empathetic, action-oriented clinician can go a long way. I invite everyone to keep these attributes in mind while I speak with Tammy, one of our main patient collaborators on this project. Welcome, Tammy. When you have a moment, can you unmute yourself? And while you do that, I'll just share a little bit of about you. So awesome. Tammy is a recipient of Undue Medical Debts Debt Relief Program, as well as a main contributor to this project. She's based in Morley, Michigan, and here to lend her voice as a patient. Tammy, we've talked at length about your experiences navigating care for multiple chronic conditions. Some of your experiences discussing the cost of care you've described as really positive and
Yes.
others as disappointing. Can you tell us about a time that your doctor helped you manage your healthcare needs and the associated expenses?
I see a specialist regularly for a chronic disease, and the prescription medication that he prescribed me is very expensive. And so I did go to him and I talked to him about maybe prescribing something different. But because of what the condition is, I needed this medicine. And so most of you probably know that drug drug reps go into these doctors' offices and they leave samples of medications with the doctors. And so this medicine has lots of samples of, and whenever I go see him, he will bring me enough to last me till the next time I see him, because the copay is so astronomical. I have to pay like $300 and some dollars every time I fill it. And that's just one prescription, and I'm on 10. So he has helped me in several ways with with the medications that he gives me, because it saves me from having to go out and get them. And when I do have to buy them, I have to kind of like rob Peter to pay Paul. And Paul gets mad eventually. Anyway, this doctor he's helped me, and he's also helped others that I know of that go to him. And he's very concerned about the cost of what patients have to pay. He tries his best to help you and work around the cost of things.
Thank you for sharing that, Tammy. I think I remember when you and I first chatted that this was a monthly expense between
Yes.
$205 to $300 for
Yes,
one of your conditions that requires long-term care.
exactly.
So it
Mhm.
sounds like in this instance, your specialist showed up in such a way that made you feel like they could solve this problem. They could eliminate the barrier, the financial barrier that otherwise would have been between you and the treatment he had prescribed you.
Exactly, because I would have cut back on treatment. I would have used less medication. Um, and, with him working with me this way, I trust him, and he shows that he cares about his patients and what they're going through.
That's great. And Tammy, is there anything else you care to share about um, how your this specialist has showed up for you and helped you navigate the the treatment and the cost and how they showed up to be supportive?
When I go to his office, after my appointment is done, he will take me into his actual doctor's office and go through all of my test results on the computer with me and explain to me everything in detail, what he's looking at, why he's looking at it, and why he prescribes this medication. So
That's
I think that is a great asset for doctors.
right, because it can make us patients feel empowered and like we have an understanding of the journey that we're about to embark on.
Exactly.
All right. Well, thank you, Tammy. And as a patient navigating multiple healthcare needs and bills, are there practices as part of the health system that you believe can discourage patients from receiving or returning to care?
Exactly. Yes, I do. I have one example. I was going for treatment for a condition on one of my hands. I have a disease that my bones deteriorate, and I needed to have surgery to fix one of my hands because I couldn't lift anything. And went to the doctor for several months. They had all my insurance information. They scheduled a surgery. And so I assumed that the insurance was going to pay because nobody ever said anything to me. And I went in and I had this surgery. And it wasn't until months later when it was sent to collections that I even knew that they didn't pay for any of my surgery. I was charged over $5,000 because they wouldn't even accept my insurance. And when I tried to call to make a payment arrangement, the person on the other end of the line in their financial department was arguing with me, telling me that, just degrading me on different comments that she was making. And then when I said, they wanted me to make $1,000 a month payment. Well, I'm on disability and I don't make that much money. I mean, that would maybe leave me $100 to live on. And I said to her, I'm on disability. I can't afford that. Can I at least do $100 a month? We will not take anything less than $1,000 a month. So at that point, I was angry. I yelled at her and I got so mad I hung up on her. And I've tried calling back to a collection agency and they want more than I can handle right now. So it's not being paid at all. And it's just very discouraging. I left that doctor's office and never went back. I found a different doctor to deal with my condition. So
Thanks for sharing that. I think it's a good example that shows the opportunity that person on the other end of the line missed. They missed an opportunity to welcome your questions and concerns, and they missed an opportunity to make you feel comfortable and heard. Because if you didn't have the money that day, you weren't going to have it tomorrow. And putting patients in an impossible situation will cause the consequence that you just described. They will seek healthcare elsewhere, and that's a missed opportunity to maintain the relationship that you already had with that particular provider. Thank you for sharing that. So this is our last question, Tammy, and then we'll pass it back to Lindsay. There are a lot of clinicians motivated to help their patients overcome financial barriers to care. What do you recommend to doctors who want to help their patients? What behavior or attitude reinforces trust between a patient and their doctor?
recently I've had something similar to this that happened. And I changed insurances and my provider has on 3 different occasions had to submit my medications because this one or that one won't be covered. The insurance company says, yeah, it'll cover it. And then they cover it a month and then it's not covered anymore. So I went last month to my primary doctor and I told her, I said, you know, they won't cover my insulin for my diabetes. She said, but I just changed it. I said, yes. I said, they filled it for 2 months and now they're telling me they can't get it. So one thing that she did that I really think that a lot of offices should do is she went out and got a hold of her specialty nurse, and she talked to her, and she went online, got a hold of my insurance company, and went through every single medication that I have, and found out the brands that they will cover so that I can get my medications. That is one thing that I feel is a very positive thing that doctors can do, is have that special person on hand that can spend the time doing that for your patients, because medication is a necessity these days.
Mhm. Well, I'm so glad that you were able to get that support. And I think you make a really good point, which is that some practices, some doctors have resources and they
Yes,
can be resourceful and they can collaborate within their institution to better support their patients and meet their patients at their needs. Thank you for sharing that. I think also just one other takeaway is we can think about how a doctor has collaborators, who can they refer their patients to help their patients navigate the cost of care while they can just focus on administering the care.
exactly. Yes.
All right. Well, thank you so much, Tammy. And I'm going to pass it back to Lindsay.
Thanks, y'all. Thank you, Tammy. And thank you, Camila. I'm gonna wait for the slides to come back up here. One moment. Okie
Oh,
doke.
I think I just had one more comment, if that's okay.
Oh yeah.
Lindsay, regarding, so before we continue, I do just want to mention and encourage everyone to take a closer look at the materials on the microsite. So there you will find other patient stories in addition to that of Tammy's. If you care to learn a little bit more about Tammy and her journey and how her providers have showed up for her and supported her, please feel free to watch her video as well as Scott, Learen's, and Harold's. Their personal stories are about accessing healthcare despite the lack of affordability are very powerful and incisive. One patient describes their journey through treatment for epilepsy. Another patient describes everything that followed after an unprecedented accident. And another patient chronicles her story after the birth of her youngest son. And as a team, we're so thankful to them for having collaborated with us on this important work. Their stories deserve your time, so please have a look. And I believe my colleague Morgan has shared a link to their stories in the chat, so please check it out. And I'll pass it back to Lindsay.
Thank you, Camila. Yeah, their willingness to let us into their homes and share their stories was one of the most powerful parts of this project. They're really, really wonderful. Okay, so champion perspectives. If you can go to the next slide. And I should do the same thing. So we provide this map as an invitation for you to reflect on where you are in your own journey and where you want to be. We developed this journey map, and you would start at the top with awareness and go all the way down to owning the issue to move yourself along the journey toward becoming a champion. So you can start by doing something as small as signing up for a newsletter and just becoming more aware about the issue. So learning more about medical debt. To something as large as owning the issue and testifying in front of your city council, your state legislature, or Congress, or like Dr. Singh in a moment, coming and doing this interview on a webinar. So I'm going to pass it to Eva Stahl, our Vice President of Policy and Programs, and she's going to get a little bit more in depth with Dr. Singh.
Great. Thanks, Lindsay. And then I think we're going to pull those slides down so that Dr. Singh and I can chat. You'll give us just a second to get set up. Awesome. Thanks, Gregory, for the support there. Hi, everyone. As Lindsay mentioned, my name is Eva Stahl. I'm the Vice President of Public Policy and Program Management at Undue Medical Debt. And I'm really pleased today to be joined by Dr. Angad Singh. Dr. Singh was a collaborator with us on this project. He is a practicing family medicine and clinical informatics physician and clinical assistant professor at the University of Washington in Seattle, and serves as Associate Chief Clinical Information Officer for UW Medicine. He's a core faculty member and has received numerous teaching and leadership awards. He also co-chairs UW Medicine's Social Drivers of Health Work Group. So, Dr. Singh, thanks so much for being with us today to chat. We really appreciate it.
Thanks, Eva.
So let's get started. So we know that physicians are not always comfortable with these cost conversations, but the cost of care is increasingly the elephant in the room, right? With more and more people struggling with the high cost of care and people even with insurance with very high out-of-pocket costs. What's really your philosophy, and what do you think the role of the clinician and other healthcare workers is?
Yeah, again, thank you for the opportunity to be here. I think as a physician, I have to recognize that the outcomes of my patient care are really only as good as the ability for our patients to participate in it. And when I, as a family physician, say things like, I provide full spectrum care, or I want to take care of the whole patient, that really has to encompass the various aspects that drive the patient's ability to take care of the health as they want to and as they choose to. So, you sort of mentioned here around social drivers of health, right? The ability to pay and financial stability or instability are key social drivers of health that have to come into the calculus of my medical decision making. If I didn't, I wouldn't really be tailoring my care to the patients that I see.
Yeah. And can you talk a little bit about how some of these issues come up in your work? You listened
Yeah.
probably to Tammy
Yeah,
tell a little
I
bit
did.
about her experience. Yeah.
So, Tammy, thank you for sharing your story. I appreciate that, and it's a vulnerable experience, I know, so recognize that and appreciate that. I would say in my work, right? So I have two kind of aspects of my work. One is individual patient care. You see, I'm kind of wearing my scrubs today. I'm just about to start patient care in about half an hour. The other is sort of in that leadership lens, thinking about high level issues around how these types of issues manifest within a given healthcare system. So on the individual level, when I prescribe a medication, for example, as you heard, it's important for me to say to patients, and I do this, if you get to the pharmacy and this medication goes beyond the cost that you would expect or that feels reasonable to you, please, in this case, there are other options, so please reach out to us. I'm giving you the medication that I think is going to meet the needs of what we're trying to achieve while also not being obscenely expensive. And so, creating permission and space for the patient to be their own advocate, often recognizing that the power dynamic is one way where I tell and patient listens, rather to say, hey, this didn't meet my needs of cost. Is there another option? And you heard Tammy ask that question. And in many cases, the answer is yes. In some cases, the answer is no. And so first and foremost, recognizing that. Thinking about my leadership lens, particularly the fact that I'm an informaticist, thinking about how information enters the experience of healthcare and technology interfaces with healthcare. One aspect that we have when we prescribe medications is we have the name of the medications when we go to order them, and then we have another column that's next to it with the relative number of dollar signs to try to give us context of, hey, medication A has this dollar sign, medication B has this dollar sign. There's also the ability for us to integrate certain technologies that look at the patient's plan and say, hey, based on this patient's plan, we think this medication will actually be cheaper or more expensive, relatively speaking. So you might want to reconsider that. Some of these have been more effective than others. We had, for example, a requirement from Medicare to provide support that when I place an imaging order, for example, radiology, a CAT scan, an X-ray, if it's inappropriate, it gives me a warning. It says, hey, this may not be the best first test. It may not be the most cost effective, may not answer the question. The problem was it wasn't working well. So we actually had to stop it, and that program was abandoned at the federal level. And so part of it is I see these aspects come in on the individual and on the population side, and it's kind of helpful to have the ability to think about both ends.
I appreciate that, and sort of just being resourceful, but at the same time, giving the patient and reminding them of their own agency is a big part of this sort of collaboration that you've talked about with patients. Can you talk a little bit about or recommend to a physician or a frontline healthcare worker wanting to learn more and do more in the clinical setting if there's some hesitancy to engage, as Lindsay pointed out in some of the research? And how do you share this with colleagues or think about this work?
Yeah, I think piece that there's hesitancy. I think there's two spaces there's hesitancy. One, it's a bit of a heroism that I think is in well-intentioned but ends up landing perhaps out of touch, which is I don't want cost to influence my decisions of just doing whatever is right for this patient. And I don't want cost to be a variable because if I include that, then I'm not thinking of what's best for this patient. And I think that I understand where that is coming from. And so I think of perfect versus practical. So, if I work with trainees, and so if a trainee, meaning a medical resident, somebody who is still completing their training before they become a full-fledged physician practicing independently, we might come up with a perfect plan, and then we come up with option A, option B, and introducing that to the patient of saying, hey, this is what I think is perfect, but let's be practical about what seems reasonable for you. For example, do I absolutely need that CT scan if you're having a little bit of abdominal pain, or can I observe this for a few days if there's no red flag signs, and then revisit that conversation if it's not absolutely critical? So those types of shared decision-making conversations I have to model, and I share that with people that I'm working with. If there's somebody who I don't have a direct teaching relationship with, for example, I think recognizing that there's a moral injury, right? We used to be physicians who had our own independent practices, who could choose to circumvent systems and bureaucracies. And now there's an increasingly employed model where realistically my agency has been diminished over time, where I can provide patient care, but I don't have that same ability to say, for this one example, I'm going to make an exception and offer this free care. You heard sort of the ability to provide two things from Tammy. One was free samples, and one was kind of thinking about prescription assistance programs. The moral injury of it is that on a population level, both of those experiences have been shown to be unhelpful for patients on large scale populations, meaning that if I get samples as a doctor, I'm not even allowed to take a pen from a pharmaceutical rep anymore, because even just receiving a branded pen that I use at home or at work has been shown to get me to more likely prescribe this medication that is often brand name and often more expensive and causing increased cost on the whole system. But for any one given patient, it provides value. So I have to also navigate that moral injury of I want to do what's right for you, but I know that in some it may not be best for patients in general. And I think recognizing when I speak to my physician colleagues that exists has been a helpful way to introduce that as an empathic approach rather than a you should do this or why don't you do this, which ultimately creates a defensive nature.
Yep, that's really helpful. And I just want to highlight that phrase, perfect versus practical, because I think that's kind of where we're stuck, right? So it's I think that feels proximal and both and also useful. So finally, I just wanted to ask you a little bit about where do you see the helpers in this space, sort of within your institution and also within the community?
So I think there's a couple spaces here. When somebody wants to get involved or try to make a difference, I always encourage folks to understand your local sphere of influence. So part of my work as being an informatics leader at the health system is I have to know everybody and what their roles are to make systems and projects be successful. So for me, it comes naturally, but for the next person, maybe they don't have that exposure. So understanding your local spheres of influence. So first off, you hear a lot about doctors, even in this conversation, there's centering of doctors. We are not the only ones in a care team. And in fact, we have the least bandwidth to make an impact. So recognizing who else in your team, in general, care team or otherwise, can make a meaningful difference. And so knowing phrases like financial assistance, recognizing that's even a possibility. We used to call it charity care. I think now it has transitioned more to financial assistance programs, for example, within the healthcare system. Recognizing what other tools exist, online tools, for example, GoodRx is a a classic tool that people use in prescribing medications and recognizing the relative cost and how that changes even pharmacy to pharmacy, knowing things like, the Mark Cuban pharmacy that you've seen online that has been shown to provide cost-effective medication prescriptions. And so first is just knowing as much as you can. And then if you're interested in bigger things, recognizing where policy does and doesn't impact this. The other piece of moral injury I didn't get to talk about was, until very recently, Medicare has not been allowed to negotiate prescription costs, recognizing that they are the largest purchaser of medications and prescriber of medications in the country, but only until recently, whereas Medicare able to negotiate only 10 medications at the federal level with the pharmaceutical manufacturers. And so in that way, we have to sort of make sure that we recognize that those are impactful legislation pieces that we can take a stand on, that you may not at the local level always be able to make an impact, but maybe at a more national level, recognizing there's turbulent times right now, but those are the types of initiatives that are value add. And then the last piece I'll just highlight before I close my time here is whether you know this or not, every health system is required to post a public file of all of their medical codes and the relative cost. So how much this exact CT scan costs and what the dollar amount is for that. The federal requirement for that is actually, it doesn't have to be quote unquote human readable. It has to be what we call quote unquote machine readable, which is a fancy way of saying a very obscure Excel file that you sort of have to take some time to parse out and read. But the next stage of this, which there's a lot of opportunity, is you take the beauty of things like large language models like ChatGPT, you feed it all of these sort of available files and you reproduce consumer-friendly, patient-friendly ways of representing information so that we as consumers can think about shopping around and we can coach our patients about, you need procedure X. I don't care if you go to this one spot. Realistically, I want you to just get this test. And if I feel confident that it's good enough, we got to make sure we go to the place that gives you the best experience at the best cost with the same outcome that we're looking for. So those types of pieces of thinking about how we can engage with patients and what opportunities I think technology can offer us is where I think the next phase will be.
That's great. That's super helpful. And I think, you lift up something that I think is really important in sort of closing our conversation today, which is the role that clinicians play in supporting patients because patients trust them. Right. And so I think, in many ways, physicians are also navigators, not just within sort of the healthcare delivery journey, right, but also in sort of, straddling some of these challenges that they face financially. So thank you so much for your time today, Dr. Singh. We appreciate it and hope you can stick around just for a little bit for our Q&A. And Gregory, why don't we pop back up those slides? Great. So just very quickly, we want to take a moment to talk a little bit about, what we experienced and talked about with Dr. Singh about the importance of being a champion for your patients. And part of being a champion is really having your message down, right? Your message is really your story, much like Dr. Singh and Tammy shared their stories today. It really communicates why you are passionate about the issue of medical debt and the cost of care and why others should care as well. So as you navigate the guide, which we're sharing today, you'll see a short video, actually clip that's shown on this slide of another physician champion, Dr. Critchlow from Massachusetts. And she really illustrates how she talks about medical debt. There are 4 components to the message structure that you should keep in mind. The first is really introducing the problem. The problem is that medical debt is pervasive, right? It burdens people financially and emotionally. Second, you need to highlight your key message that no one should go into debt for accessing the healthcare that they need. Third, this is where your story really comes in, and it is about providing evidence. So for a clinician, this is what makes your message your own. So using a story of a patient or an interaction that really stands out to you. For example, my patients are struggling with the cost of care. Patients delay or forego care or don't fill a prescription to avoid medical debt. We heard this in Dr. Singh's story. We heard this in Tammy's story as well. And then finally, including a call to action. So this might just be creating awareness around the issue of medical debt as you contemplate what practices and policies that you might see within your practice and institution, or as Dr. Singh noted, that you're toggling yourself between like what's happening locally and other and federal and state conversations that are happening around the issue of medical debt. Next slide. So as with any messaging, understanding your audience is really critical. So the guide also provides you with a short set of questions to ensure that your message aligns with the values of your audience. We call this value-based messaging. So you might frame up your action or request differently for an institutional chief financial officer than you might for a community partner or a policymaker. So really taking a moment to ask yourself these questions can increase your effectiveness as a messenger. So once you sort of poke around in the guide, you'll find that it provides several tools and can help you develop your pitch. So we hope that you will take a dive in and see what you can do. But there, you'll note on the right-hand side that there's a tool to create a short elevator pitch. This is really easy and fun to do, as well as a set of questions to consider. And those are just important components to being a champion. Next slide. So with that, I'm going to hand it over back to Gregory Brody, our program manager for community partnerships.
I'm unmuted. Thank you so much, Eva. Again, I'm Gregory Brody. I'm the program manager for community engagement, and I just wanted to share one slide talking about, I wanted to have shortly we'll bring on Gary Renville, but before we do, I just wanted to share within the guide, there's embedded like a 2-pager for community-based organizations who have a stake in this work, but want to know their, essentially their role. So if we could, after hearing from Tammy and Dr. Singh, where we were thinking through the individual's experience within this, I just wanted to take a moment and some time to expand the scope to think past the individual in these exchanges to build the change that we need. So within the 2-pager, it will build on the work that community-based organizations can do. So we'll include that in the resources we send out, building awareness with your community, engaging and partnering with clinicians, cultivating clinician champions, and sharing the guide. To discuss that firsthand and kind of in conversation, I'm going to bring on, one second, I'm going to spotlight one. I'm going to bring on Gary Renville, our guest, to kind of talk this out. And I'm going to, one moment, and allow me to, so Gary, if you're good, I'm just going to introduce Gary real quick. So Gary Renville is based in Seattle, Washington, and currently serves as president and CEO of Project Access Northwest, a nonprofit organization serving all of Washington state, providing expert care coordination to strike down barriers to health and healthcare, addressing social drivers of health for uninsured and underinsured Washington state residents. Currently, Gary volunteers as the board chair of the National Communities Joined in Action Board of Directors, CJA, and as a board chair of Pacific Medical Centers. So Gary, thank you so much for joining us.
Thank you, Gregory. It's a pleasure to be here.
Wonderful. I'm going to jump in to some questions and conversation that we can have on this work. So community partners are key players in the healthcare space, often acting as bridges between patients and social services, or just simply with the access to healthcare. While the research presented today is focused on healthcare workers and clinicians, what role can community-based organizations play in the broader healthcare landscape? Could you speak to that?
Yeah, Gregory, I'm happy to do so, and thanks for the invitation. I think before I do that, I wanted to share just a couple of quick notes of gratitude, which will kind of ease me into my answers as I follow the brilliance that is Eva Stahl and Dr. Singh. I want to share gratitude after having already watched Tammy's video found through the microsite provided by Undo Medical Debt. I just wanted to share my gratitude for being able to hear directly from Tammy as she shared her story and her experience navigating access to healthcare and her experience with medical debt. And I also wanted to share my gratitude to my fellow CJA board members that I see on today's call, and gratitude to a number of current CJA members that I also see on the call. So now I'm eased in. So yeah, Gregory, to kind of get to your question, I think overall CBOs, community-based organizations, bridge gaps, right, in healthcare systems, focus on holistic approaches that integrate social, economic, and environmental factors into health and wellness initiatives. Their work, our work, I'll use those two words interchangeably, is essential to and for creating healthier communities and promoting health equity. I think some of the key contributions that CBOs make, to further answer your question, is that we provide or connect people to essential health services, including screenings, vaccinations, and health education, particularly in underserved communities where access to traditional healthcare facilities might be limited. Provide support for vulnerable populations. CBOs frequently serve marginalized groups, including low-income families, racial and ethnic minorities, and individuals with chronic illnesses. We work to address disparities in health access and outcomes. We link patients to resources. We can connect individuals with a wide range of community resources, including housing assistance, food security programs, mental health services, and substance use treatment, thereby addressing the social drivers of health that Dr. Singh and others have talked about to influence health outcomes. Innovative health solutions. CBOs often pilot innovative approaches to health and wellness, testing new strategies for engaging communities and improving health outcomes. CBOs provide advocacy for policies that promote health equity and improve community health standards. And finally, answer to your question, we collaborate with healthcare providers. We collaborate with healthcare facilities, government agency, and public health organizations to create comprehensive care models that encompass prevention, treatment, and community support.
Thank you so much, Gary. It actually addresses a follow-up question that I would just share, is the why community-based partners are so integral, and everything you kind of just listed not only answers the why, but also kind of reiterates the idea of the role of the community-based organization as the true barometer of the situation, right? And as a way to kind of broach the gaps and the barriers, not only in care, but between patient and provider. So I appreciate that. I wanted to follow up with a different question. As a leader in this space, the they and I that you're speaking to, what are some key strategies that work in partnering with healthcare systems to build that agency and to maybe elevate the kinds of messages that we're trying to instill for physicians and around in the healthcare landscape?
Yeah, I appreciate that as well. And wonderful that I was able to tick off two questions with one answer. I love that. Yeah, so, and I'm preaching to the choir here and recognize we have a number of people on the call who really are experts at this as well. So I'm answering this on their shoulders. But I think that, key strategies that I've seen working with CJA members and others that I've come into contact with, and certainly at my own organization, I think it's important to establish clear goals and objectives and to align the goals of the partnership with the needs of the community and the priorities of the healthcare system. I think clearly defined objectives help to maintain focus and demonstrate the value of collaboration. We've heard it said in a couple of different ways, but I would double down in saying building trust and relationships is paramount. Fostering open communication and genuine relationships with healthcare leaders and practitioners. Building trust is critical for long-term collaboration. It ensures that both parties feel comfortable sharing insights and resources. I'd say that another strategy would be to engage stakeholders early on and throughout, and bring together a diverse group of stakeholders from both the community and healthcare organizations, including patients, community members, local businesses, and other organizations, and really engage a wide array of voices to ensure that the partnership is inclusive and responsive to community needs. I'd want to talk about and highlight a focus on culturally relevant interventions, and designing and having that eye to partnerships that are tailored to the cultural and social context of the community, to improve engagement and the effectiveness of health interventions, if you will. Two others advocate together, join forces to advocate for policies and initiatives that benefit both community health and the healthcare system, like addressing social drivers of health and improving access to care. And then finally, because the work can be hard, right? Celebrate successes, recognize and celebrate achievements, no matter how small, and highlighting successes, recognizing that that helps to build momentum, strengthen relationships, and motivate all partners to continue their collaborative efforts.
That's perfect. Thank you so much. There's one kind of closing question around kind of what's a first step, like thinking through the first or a few steps. It doesn't have to be one, right? But what would be a step that a community partner could take to begin this work, advocating for, the clinician champion in their network?
I love it, Gregory. And thanks for sending the questions to me ahead of time. And as you know, I can't just answer it with one answer. So I'm like, first step. Well, there's a few steps, but I'll limit it to two. First, I would say join communities in action if you're not already, as an individual or as an organization. A national nonprofit made up of local and regional community health collaboratives, all of which are committed to better health for all people at less cost. And then secondly, I would say as a next step, or as a step right alongside that first step, take advantage of the great resources made available by Undo Medical Debt and share those resources with your network of providers, community health workers, volunteers, and funders. I think that we've seen in the materials share, right, that the key message is that no one should go into debt for accessing the healthcare that they need. And the objective is to end medical debt, and healthcare workers are key messengers for that and well positioned to drive the conversation. So as you read or reread Treating Medical Debt, a guide for clinical champions, or the guide, you'll see the resources created provide really a strong roadmap for others to build allyship and common cause in addressing medical debt.
Thank you so much, Gary. I realize we were talking about one of the resources I'm just sharing directly into the chat is the 2-pager that we have for community-based organizations to navigate this work directly, or navigate the work in elevating the toolkit. But I think embedded in that larger advocacy and policy landscape is not only the CJA network, the Communities Join in Action network, but just like empowering the agency to realize how much a part that the CBOs play in this. So thank you so much. We have a few questions, so we're going to transition to a broader Q&A. But Gary, thank you so much for making the time and talking with us today, all things community-based organizations. Okay, and one. No, sorry. So momentarily, we're gonna move to Q&A, and I'm sorry, I'm trying to fix the. Okay, great. So thank you all so much, and thank you to all the panelists and presenters moving through the webinar presentation. I realize we're closing on time, so I just want to make sure we can have at least time for 1 or 2 questions. We'll be following up with resources after the call, but let's just jump in and tick off at least, I apologize, 1 or 2 questions for Q&A before we round out the call. And I believe we have one question first for Dr. Singh. Well, yeah, for Eva and Dr. Singh, if Eva and Dr. Singh could just speak to, sorry, for Dr. Singh, it says, can you talk a little about opportunities to learn more about resources to help your patients and shifting policy to help people avoid medical debt?
I'll clarify. Maybe you can help me clarify that. Are you talking,
Please.
Is the audience of my comments of how I can coach patients with shifting policies, or resources for clinicians. And that's the piece. I don't know if it's clear there, or maybe Ava, you unmuted if you had any thoughts from that too.
So I think resources for clinicians. So you highlighted sort of the policy pieces around the emerging work on prices. I would just add to that is knowing whether or not you participate in your financial assistance policy. So as required by the Affordable Care Act, all nonprofit hospitals have a financial assistance policy, as Dr. Singh noted, sometimes called charity care. So sometimes we find more often than not, patients don't know about this opportunity on the patient side. And then on the physician clinician side, some clinicians opt not to participate, but they might not be aware because of how the billing systems are set up, and physicians sort of run in a different stream than hospital billing. So that would just be, those are just key things to note. And then Dr. Singh also raised up all the great resources around researching different prices for pharmaceuticals. So I don't know if there are other things that come to mind, Dr. Singh.
I mean, for me, the piece is like, I bet you a very limited percentage of folks on my colleagues have actually reached out to somebody who does the next step, right? So I would encourage folks to at least just pick up the phone or send an email and say, hey, if my patient has questions about cost, what are the resources available in my network? And that's often just asking somebody on your own team. I like to think about mapping the patient journey from the time they walk into my office to the time they leave, thinking about care in my four walls and care outside of it. And so in that way, just taking a step back and saying, what happens when this patient leaves and how do they navigate it and how are we approaching them, would be that first piece. In terms of larger resources, I did see on the Undue Medical Debt website at the top right, there was sort of like a resource link and a toolkits. And so I know that's available. But the ones that I sort of start with, again, are the GoodRx and looking at other sort of pharmaceuticals is the easy one, so at least starting there is reasonable. The imaging pieces is a secondary step of knowing what imaging facilities exist in your local network. And those two capture a lot of the bulk of what ends up being the easy cost conversations to have. And so at least starting there is value add.
Thank you so much, Dr. Singh. And thank you, Eva. And thank you all for attending. Thank you, panelists and presenters and interviewees. We are actually closer to time than anticipated, so I apologize for that. But I just wanted to close out the call again, extending my gratitude for all attendees and everyone who spoke today. I just want to mention that this work was funded by Robert Wood Johnson Foundation, and in this work we collaborated with Communities Joined in Action (CJA), as well as with Perry Undum to do our messaging research, to do our focus group research and the qualitative elements. Thank you all so much. We'll be again distributing the recording and the slides as well as all the resources. We mentioned a lot of different resources. It's all within the microsite that we'll be sharing. And I hope everyone has a great rest of your Friday. Thank you all so much for joining.